right, so welcome to this lecture. And in this lecture, we are going to be talking about perioperative nursing. And of course, you will realize as we move ahead that perioperative nursing can also be called operating room nursing. And of course, it is divided into three, phases. There's what we call the preoperative phase, there is the intraoperative phase, and then the post-operative phase. And in here, basically, we look at all these phases one by one, and basically what happens in each phase. So in a few slides, we are going to go through these phases, and you should be able to appreciate that, indeed, for a patient to be operated upon, or for any patient that is going to be operated upon, there is need for physiological monitoring, need for psychological monitoring, need for psychological support, and need for support as far as sociological support is concerned, especially for the patient, but also for the supporting, for the relatives or for the family. So, as we start, of course, in this topic, there are quite a number of definitions that you will find and you will read more in your presentation. Yeah. So definitions like surgery, definitions like who a surgeon is, what we mean by a surface which is sterile, and among other definitions, as you will see in your presentation. So we shall not spend a lot of time in these, in these definitions, but you will, and I'm sure you know some of these because you are practicing nurses, yeah? And so you will come across some of these definitions in the presentation. We shall not spend so much time on them. And also prefixes and suffixes, when we mean a prefix is basically what starts a word, and then the suffix is what ends the word. So when we say supra, it means above, and then also basically means joint. And so you will come across all these, these suffixes and prefixes in surgery as you move along. So, but we shall not spend a lot of time on these, right? Okay. So, of course, as we move on, surgery, surgery as a definition, you will come across it. Operation, what does it mean to have an operation? Of course, I'm sure you know what it means already. Now, moving on, of course, as I said earlier, perioperative nursing, this can also be referred to as operating room nursing. And in here, the main aim of, operating room nursing is basically we want to look at the physiological, we want to look at the psychological and the sociological needs of the client and how we can help this client to go through the operative, the operative procedure. Yeah. And as we are going to see, it can be, as we do the different nursing interventions that we do, basically arranged in the different phases, in the preoperative, the intraoperative, and then the postoperative. What exactly do we do in these phases, right? All right. And of course, it goes with the philosophy of, of providing comprehensive support, physiologically, spiritually, psychologically, morally, to a patient. But not only to a patient, but also to the family of this patient who is to go or who is to undergo surgery. Yeah. And of course, the goals are to provide safe and supportive together with comprehensive care, assist the surgeon by functioning as an effective member of the surgical team. We are going to see that, during an operation, it is not only the surgeon. No, it is not. But it is basically a team, yeah, among which are nurses, yeah. So the nurse basically acts as an effective member as far as operation is concerned. Yeah. So also creating and maintaining an aseptic environment. Yeah. It is very important for the nurse to maintain an environment which is aseptic, yeah, an aseptic environment, aseptic. So an environment that is free, an environment that is free of microorganisms, yeah, an environment that is free of microorganisms, yeah. So it is one of the goals of of nurses as 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 the procedure is basically going on, right? All right. So as earlier on said, we said that perioperative nurses has basically three phases. Yeah, it has three phases, and we have what we call the intraoperative, intra. No, actually, the intra is the second, but the preoperative, the preoperative, pre. We have the intra, and then the postoperative. Yeah. So postoperative, intraoperative, and then the preoperative things. These are the phases that basically comprise, perioperative nursing. And so you need to know exactly when each phase starts and ends, and actually what happens, what happens in each phase, right? So when does the preoperative phase begin, and when does it end? Yeah. So the preoperative, the period of time from when, the patient, decides to, or from when a decision is made, for surgery. Yeah. Either, the decision might be made, of course, the patient has to be involved, and also the surgeon. So from the time when decision is made that this patient is to undergo surgery, yeah, up to until when the patient is transferred into the operating room, yeah, that is what we refer to as the pre-operative, yeah. So from when the decision is made up to when the patient is transferred into the room, yeah, that is what we refer to as the pre-operative, phase of perioperative nursing. And then the intraoperative, this is, the period, from when the patient is transferred into the operating room, yeah, into the operating room, up to the time when the patient has been, when the surgery has been completed, and the patient is now transferred into PACU, or what we call the post-anesthesia care unit. Yeah. So from the time the patient is transferred into the operating room up to the time when the patient is exiting the operating room into PACU, yeah, that is, the intra-operative phase. And then lastly, we have what we refer to as the post-operative phase. And of course, in the post-operative phase, this one begins from the time a patient is admitted into PACU, up to when, the time the patient is being followed up, is the patient improving up, basically follow up, yeah. Even at home, yeah, up to when the patient, or up to when the surgeon basically removes his or hands from the patient, declaring the patient, to be free now of any risk that or any danger that are associated with any kind of surgery. Yeah. Now, having known these phases, it is very important for us to know exactly what happens in each phase. Yeah. It is very, very important for us to know exactly what happens in each phase, and who are the stakeholders, and who are the players in these different phases. So we are going to look at one by one to see what actually happens in each phase. What is the role of a nurse? Yeah. What is the role of a nurse in each phase? What is the role of a nurse in each phase? And who are the different other players in each phase? So we're going to look at one by one, yeah? And of course, you will come across this in your presentation, the classifications of surgery, which are not going to, we are not going to spend so much time on this, yeah? But of course, surgery can be classified according to urgency, yeah? It can be classified according to you know, to the degree of risk, yeah? Where we have minor or major surgery, yeah. It can also be classified according to purpose, yeah. Is it diagnostic? Is it exploratory? Is it curative? Is it palliative? Among others, yeah. So basically those are the classifications of surgery. It can also be classified according to location, yeah. Is it internal or is it external? So we are not going to spend so much time on that, yeah. And of course, we also look at the four basic, basic conditions that require surgery. Conditions like obstruction, conditions like perforation, conditions like erosion, tumors, those are things that basically require surgery. And of course, we also need to know which people are basically at risk, yeah? Which people can be at risk, as far as surgery is concerned. People who have extremes of age, people who are, people who are either obese or emaciated, people who are dehydrated, people who have nutritional deficits, like for example, the malnourished, people who have severe trauma, who have severe infection, people who have cardiovascular diseases, endocrine dysfunction, and so among others. Of course, the hypotensive, hypovolemic, people who have liver disease, and the pre-existing either mental or physical disability. Now, it is very important for you to know this, yeah? Is to know whether a patient is at risk of surgery or not, yeah? And what can you do to really rectify this problem if the patient needs surgery? Like, for example, if a patient is dehydrated, before you do surgery, to make sure that the patient is well hydrated. If a patient has a nutritional problem, like for example, if they are malnourished, then please make sure that they are in their nutrition status, normal nutrition status, or that the nutrition status has improved before surgery is done. If they have sepsis and infection, please first make sure that the infection is handled, yeah? If they have uncontrolled blood sugars or if they are hypertensive, it is the role of the medical team to make sure that the blood sugars are stabilized, or even the blood pressures are stabilized before this patient undergoes any form of surgery. I hope that is clear. All right. So we also have problems that may arise, or what we refer to as complications that may arise as a result of surgery. Things like, pain, hemorrhage, infection, postoperative infection. Now, this is very, very important. Yeah, sepsis that usually comes as a result of, postoperative. Yeah, and of course, urinary tract infection. All these can, as a result of insertion of, catheters, yeah, catheters. So these might be complications, or these might be problems that might arise as a result of, a patient undergoing surgery. And so a surgeon, not only the surgeon, but the medical team, the nurse inclusive, should be aware of some of these things, because the nurse will also be able to, to play part, or the nurse is able to play part as far as these problems or complications are concerned. All right, so let's move on to the different phases, yeah, and of course we shall start from the pre-operative phase, yeah, the pre-operative. All right, so in the pre-operative phase, As remember, we said this starts. When does this start? It starts from when a decision, is made to have surgery, up to when a patient is transferred into the operating room. Yeah. So, what are some of the things that are done? So, the rendering of nursing care to the surgical client as soon as they are admitted and the decision to undergo surgery has been made. And of course, it ends, as we say, it ends, it ends at the time when the patient has been transferred into the operating room, or what we refer to as the OR. Okay, so what are the different nursing activities? Yeah, remember we are looking at perioperative nursing. Yeah, and so the nurse plays part, or the nurse needs to play a role as far as the preoperative phases is concerned. And so the different nursing activities, of course, we shall look at them in detail. Yeah, but assessment of a client, yeah, to obtain baseline evaluation. Ladies and gentlemen, that is why you do health assessment. Yeah, that is why you have health assessment as a course unit. Yeah, in your in your nursing curriculum. Yeah, because you will need to assess a client. Yeah, you will need to do a thorough health assessment of this client to obtain baseline, information, or to obtain baseline evaluation of the patient before the day of surgery. And of course, assessment basically involves three things. It involves one, history taking. It involves two, physical examination, and of course, documentation of your findings. Yeah. So you need to do a thorough assessment of this patient to obtain baseline information before this patient is to undergo surgery. Yeah. Good. Now you also need to identify, potential or health problems, yeah, that this patient has. Does this patient have any risk factors that we have talked about? What are the needs of this patient? Yeah, before, or the needs of this patient who is to undergo surgery. Yeah, things like also pre-admission testing. Of course, we are going to look at these in detail, but you need things like CBC, you need RFTs, you need things like grouping and cross-match for this patient, and these blood or these investigations are basically, if they are labs, yeah, the blood or the blood is basically drawn by the nurse, yeah, and then preoperative teaching, yeah, involving the client and and support person, yeah. We are going to look at preoperative teaching, and in here you look at things, what are some of the things that the patient needs clarification as far as their surgery is concerned. Remember, it is the role of a surgeon to carry out informed consent. Yeah, and so and it is the role of the surgeon to make sure that this patient signs for for a procedure that they are well acquainted with, because the surgeon has explained. But it is the role of a nurse to make sure that in case the patient needs more information about the procedure, in case the patient has some worries about the procedure, then the nurse should stand in position to be able to address these concerns from the patient. Yeah. So preoperative teaching involves some of these things. Yeah. What are some of the medications that will be given to the patient? Yeah. What are some of the exercises that the patient will be required to do when after surgery? So all this happens in preoperative teaching. All right. Then on the day of surgery, what actually happens? Patient teaching is reviewed. Informed consent is confirmed. The patient's identity and surgical site is basically verified, and also IV fluid started. Of course, the cannula inserted, and of course, IV fluids are started on the day of surgery. All right. So as far as the preparation for surgery is concerned, what does the nurse have remember we said you physiological needs, psychological needs, psychosocial, psychosocial needs for both the client and and of course the family or the support family. Yeah. So as far as the psychological support is concerned, you assess or you allay, the client's fears, anxieties, support systems and coping patterns for this patient. What do we mean by assessing client's fears? Some patients, even if it is a health worker, by the way, even if it is a nurse or a doctor, we all have fears, we all have fears as far as surgery is concerned. You have fears, will I survive? Will I come out of this, out of this surgery? Will I be able to function normally as I did before the surgery? So it is the role of the nurse to allay these fears or to allay these anxieties. Yeah, but not only do this, but support the patient as they undergo through this. The surgery. When you know that you're going to undergo surgery, it's not a simple task. No, it's not a simple task, especially if it is major surgery. Yeah. So the nurse needs to support both the client and the family, and to help them cope up, help them cope with the with the decision or with what is going to be done. Yeah. So that they go when they are, when they are not anxious or when their fears have been allayed or when their anxieties have been allayed. Yeah. Then it is the role of a nurse, to really establish what we call a trusting relationship. Yeah. With the client and and significant others. Yeah. So make sure that the client really trusts you. Yeah. Please make sure that you win the trust of the client. Yeah. As a nurse, you win the trust of the client, but not only the client, but also the family. Yeah. You have to make sure that they trust you, that you will be able to help them go through this situation of surgery. Yeah. So you need to explain routine procedures. Encourage the patient to verbalize fears, and also allow the client to ask as many questions regarding the surgery as as possible. So all this happens as far as the psychological support is concerned. Also demonstrate confidence in the surgeon and staff. Yeah. So as you talk to the client or as you talk to the patient, please make sure, yeah, that you instill confidence that the surgeons and the staff, they really know what they are going to do. Yeah. The surgeons and the staff, they know what exactly they are going to do. Yeah. So please, confidence in the surgeon and the staff who are going to work on the patient. Yeah. So please instill the patient in that. Then spiritual support. Yeah? Spiritual support. There are some patients who might want you to pray with them. Yeah. As far as the spiritual context is concerned. So if they request you to pray with them, please go ahead and do that. Or if you can request them, to pray with them and then they accept, please go ahead and do that. Because as nurses, it is our role to spiritually support, it is our role to spiritually support these patients in whatever kind of condition. It might not necessarily be surgery, yeah? It might not necessarily be surgery, but it is our role to support these people in whatever kind of situation they might be in. And if it need for spiritual support is needed, then please go ahead and do that. Or link them to someone who can support them spiritually. And so they will greatly appreciate all this that you're actually doing for them. All right. So what happens, or what do we do as far as the the preoperative teaching is concerned? Yeah. So This is frequently, in most cases, it is done on an outpatient basis. Yeah. So from the time a decision is made to have surgery, yeah, then the client is given, certain types of teaching. Yeah. Do not wait up to the day of surgery, or do not wait only until the day of admission for surgery, and then you start teaching the patient, or when the patient is, and then the patient is told, yeah. If there is opportunity, especially with elective, surgery, yeah. If there is opportunity, yeah, then the preoperative teaching should start as early as possible. Yeah. Of course, we are not saying that we are not saying that it is a must that it should start on outpatient basis. No, because some surgeries are not planned. Yeah, some surgeries are not planned. But we are saying that if there is an opportunity to start the preoperative teaching as early as possible, especially on outpatient basis, then that would be very, very good. Yeah. Now, so frequently done on outpatient basis, assess the client's level of understanding of the surgical procedure and the implications. Yeah. So you need to ask the patient, what do you think? Yeah. What do you understand by the procedure that you're going to undergo? Yeah. And what do you think are the implications? Yeah. Do you think you will be fine after the surgery? So you assess understanding. Yeah. You assess the understanding of this patient as far as the surgery is concerned. Yeah. And also answer questions, clarify and reinforce explanations given by the surgeon. Remember, as earlier on saying, it is the role of the surgeon to do informed consent, yeah, to address all the issues that the patient is, the patient has before a particular surgery is going to be done, how it is going to be done, what are the risks and benefits, among other things. But it is also the role of the nurse, to clarify, to reinforce explanations, that we are given by the surgeon earlier. Yeah. So it is very important, and all this happens in the preoperative teaching. Routine, explain the routine pre and postoperative procedures and any special equipment that are going to be used on the patient. So all this basically happens in the preoperative teaching. But not only that, yeah. You also, talk about. You can also talk about the preoperative experience. The preoperative medications. What are some of the medications that are going to be given to the patient, before operation? Any kind of breathing exercises, especially if the patient is to be operated on the abdomen. Yeah. So breathing exercises. The patient needs to be told how they should be able to, to protect their abdomen so that it does not get so that it does not give way, yeah, after operation. So breathing exercises, coughing. What are the coughing techniques? Yeah, is there a need for incentive spirometry? Yeah, so all these should be taught to the patient before, before the operation. Yeah, leg exercises. Yeah, what position changes and movement will be expected, for this patient. Yeah. How is the patient's pain going to be managed? What are you going to use to manage the patient's pain? Yeah. And how should the patient tell you that they are in pain? Yeah. Also reducing anxiety and fear, support and coping patterns for this patient will also be very, very important. Yeah. Special consideration should also be put in place, related to outpatient surgery. Yeah. So if it is a one-day surgery, that you come in and then after operation, then you go away. So you also need to let the patient know, yeah, whether it is a one-day surgery or whether they will need to be admitted in the hospital for some time. Yeah. So this is also very, very important. Now, these are some of the examples of the diaphragmatic breathing and then sprinting when coughing. Yeah? So you need, as a nurse, you need to teach this to the patients, especially those patients who are going to undergo, operation on the abdomen. So those are some of the examples of the diaphragmatic breathing and stoppages, of course, these are very important, especially for those patients, to prevent, deep vein, thrombosis. Yeah. So those leg exercises are very, very important to teach to these patients, yeah, before operation. In other words, operatively. Yeah. So the different interventions, physical preparation, patient safety is also very, very important. Yeah. In other words, to make sure that the patient is safe. Yeah. Make sure that the patient is safe. Sometimes patients are given pre-operative medications that make them dizzy. Like, for example, we are going to see that there are some anxiolytics that are given. Yeah. And once they are given, these medications can make them dizzy. So it is your role to make sure that these patients do not fall off their bed. Yeah. So patient safety is very, very important. Yeah. Obtain history of past medical conditions, surgical procedures, dietary restrictions, and any medication this patient is on. Remember, we said assessment. Yeah. And in assessment, of course, this is where you do history taking. Yeah. So you do all that. Yeah. Obtain baseline do a baseline head-to-toe assessment, including vital signs, height, and then weight of this patient. Yeah. And then also ensure that diagnostic procedures pertinent to the surgery have been performed as ordered. Like, for example, if a patient is to undergo maybe some kind of cardiac surgery, then ECG, ECG echo maybe, is pertinent, to this procedure. If a patient maybe was to undergo, maybe abdominal examination, then probably ultrasound, yeah, ultrasound was probably pertinent to this. So it is necessary to ensure that diagnostic procedures pertinent to surgery are performed as ordered before the surgical procedure. Yeah. Now, what are some of the investigations that are basically done? CBC, electrolytes, PTINR. PT basically means prothrombin time, and then PTT is partial thromboplastin time. Now, these give us a clue on the bleeding and the clotting, the clotting time of the patient. Yeah, and then urinalysis, ECG echo, blood grouping on cross-match, among others. Yeah, so of course some might need X-ray, some might, depending on what kind of surgery that is going to be done. But of course, the routine ones that must be done for any kind of surgery are things like CBC, electrolytes, PTINR, urinalysis, and then grouping and cross-match. Now, these are very, very essential and crucial for any kind of surgery that is going to be performed. Of course, kneel for us to prevent aspiration, especially if it is going to be, some kind of internal surgery. Yeah, it might, especially if it's going to be internal kind of surgery, then kneel for us. Yeah, then bowel preparation and skin preparation. Yeah. Is very important, cleansing enema or laxative, before surgery to allow for satisfactory visualization of the surgical site, especially if it is, within the colon, or if it is, some kind of procedure that has to be done, in the lower GI. Yeah. So the goal of skin preparation is to basically decrease, bacteria without injuring the the skin. And so and by the way, there have been some changes and of course, depending on the hospital policy and then maybe surgeon's preference. Usually, skin preparation is if it does not require much work, then it can be done within within the operating room. But of course, if it will require much work, then it is done earlier before the patient is transferred to to the OR. Yeah. So immediate pre-operative preparation, complete what we call a checklist and chart. Yeah. So here, depending on hospital policy, on the different hospital policies, you know, they usually have the checklist. Yeah, they usually have a checklist and a chart where you need to complete that. You know, this is in check, this is in check, the other one is in check, something like that. Yeah. So you make sure that checklist is complete before a patient is to go or is to be transferred, you know, to the operating room. Yeah. Hospital gown, you know, voiding, removal of dentures, jewelry, or even any contact, like for example, lenses, you know, contact lenses, all these are removed. And then pre-operative medication. We are going to look at some of the pre-operative medication that is given, you know, before surgery. Yeah. Then transporting the patient to the pre-surgical area about you know, 30 to 60 minutes before anesthetic is given. And then you know, attend, you know, to family needs is also very important. Maybe the other thing that is very important that we might not have looked at is that this patient is not only you know, is not only to be seen by the nurse, yeah, but this patient is also to be seen, you know, this patient is also to be seen by the by the by the anesthetist and also the, you know, the surgeon. Yeah. So it is very important that that the patient also undergoes anesthetic review, or even also you know, yeah, anesthetic review is very, very important, because of course it is a must that the surgeon has to see this patient, but this patient also, it is very important that they undergo what we refer to as anesthetic review, right? All right. So it is also very important that as you attend to the family, as you attend to the patient, also you attend to the needs of the family, right? Okay. So we want to look at, you know, we want to look at what we refer to as legal preparation of the patient. And one of the things that should not miss in the legal preparation of the patient is what we refer to as an informed consent. Yeah. So what is involved in the informed consent? You know, the surgical procedure, of course, this is done by the surgeon. Yeah. This is the primary work or the primary role of the surgeon. Yeah. So what happens here is that the surgeon basically engages the patient. Yeah. Of course, in the presence of a nurse. Yeah. In the presence of a nurse, the surgeon engages the patient. Yeah. You know, as far as the procedure is concerned, in the presence of the nurse, and what is entailed or what is involved as far as the consent is concerned. Once the surgical procedure itself, what is going to be done? What the surgeon is going to do, right? What are the possible alternatives? That if the surgery is not done, what else can be done? And how beneficial would those other possible alternatives be? Yeah. Then what are the possible complications of the surgery? Yeah. These should be explained to the patient. Yeah. What are the possible complications that will come out of the surgery? And then what disfigurement will occur, or removal of what will occur? Yeah. If it is hysterectomy, then you need to, you know, you need to explain that, you know, we are going to remove this and that. Yeah. If you're going to remove one part of the fallopian tube, then you need to explain to the patient. Yeah. So what disfigurements are going to happen? Yeah. All this is explained by the surgeon. Yeah. What are the benefits of the procedure? Yeah. And by the way, this should be done preferably in the language. Yeah. In the language that the patient understands. Yeah. In the language that the patient understands. Now, it is, you know, it is part of the nurse's role to act as the patient's advocate. Yeah. So to confirm whether the client has basically understood all this information, yeah, that the, you know, that the surgeon is giving to the patient, right? All right. So informed consent is necessary. Yeah. in the following circumstances. If it is invasive procedure, so if it is going to be an invasive procedure, you know, things like incision, biopsy, endoscopy, paracentesis, it is required. Yeah, a procedures requiring sedation, you know, non-surgical procedures such as arteriography or angiography, you know, procedures involving radiation, you know, in all these informed consent is basically required. Yeah, and of course, who is to give, you know, who is allowed, you know, to basically give informed consent is, you know, another client above 18 years. We looked at this already when we were doing introduction to nursing. But another client who is above 18 years may sign, you know, and they may sign their own permit, you know, unless they are unconscious or mentally incompetent, as we said earlier. Yeah? And if unable to sign, then we get, you know, the medical, what we refer to as the medical proxy, yeah, or the healthcare proxy. And in this case, it can be a relative, you know, it can be a guardian, you know, or the next of kin, yeah. And of course, in an emergency, permission via telephone or might be, you know, might be required, yeah. But of course, if this is not possible, then the patient, then upon the discretion of the surgeon, then the patient can be rushed into theater in case it is an emergency. Now, consent might not be needed. In case of emergency if all four criteria are met. There is an immediate, you know, immediate threat. Like experts agree that if that this is an emergency, or the client is unable to sign, you know, consent, or a legally authorized person cannot be reached, or what we refer to as the healthcare proxy here. So in all this, if a patient can straight away move to theater if all these have been satisfied. And so there is no need for, there might not be no need for consent. Yeah. Minors, of course, must have consent signed by an adult, yeah, a parent or a legal guardian, yeah. And emancipated minors, married or independent, and his or her own, you know, may give or may sign his or her consent. We saw this. And of course, the emancipated minors, you know, the pregnant, they might be under 18 when they are pregnant. We have those who have joined the army, you know, when they are under 18. The married ones, or people who all those who have their own, who do their own earnings, yeah. All these are referred to as emancipated minors. Yeah? So these may give their own consent. Yeah? All right. So witness to informed consent may be by a nurse or by another medical, medical personnel, or it might be by a clerk or any other, authorized person. Yeah? So the nurse witnessing informed consent specifies whether witnessing explanation of the surgery or just signature of the client. So this is very important. The nurse who is witnessing informed consent has to specify, was the nurse there when the patient was being explained to, or they are basically just witnessing that, the client basically signed, on the informed consent. Now, this is very, very important, right? Okay, so we remember we said that there are pre-operative medications, yeah, pre-operative medications that are usually given, yeah. And basically, what are these medications? Yeah, the pre-operative medications that are usually given. Yeah, they are usually given pre-operative medications. Now, these medications, basically, what is their purpose? Their purpose is we are going to see, like, for example, anxiolytics. They relieve fear and anxiety. Yeah. Then there are those that basically reduce those needed for induction and maintenance of anesthesia. Then, of course, to prevent what we call reflex bradycardia that happens during induction of anesthesia. and also to minimize oral secretion. Now, so that is those are some of the purposes or the uses of the preoperative medications that are usually given to the patient before they are to undergo surgery. Now, what are some of these examples? We have we have the sedatives, the anxiolytics, yeah, the anxiolytics, the ones that basically relieve anxiety and fear, yeah. Things like things like diazepam, yeah, things like diazepam, midazolam. Those are the commonest that we give, but also they can give phenobarbital. So depending on the need, yeah, those can help to decrease anxiety and fear by the patient. Then we have those that help to relieve pain. The narcotics, we have examples like demerol, dilantin, morphine sulfate. Now, morphine sulfate, pethidine, these are very, very common, yeah, especially in relieving of pain, and fentanyl, yeah. But as you give these, it is very important, especially in narcotics. As you give these, you check narcotics or opioids, yeah. You check on the respiratory system, yeah, because they tend to depress the respiratory system, yeah. So basically, those are the opioids or narcotics, yeah. Then we also have what we call the anticholinergic. Of course, you do this pharmacology. I'm sure you have. I think you have not started with pharmacology, but if you have started, maybe then you have looked at the anticholinergics. But if you have not started, you will come across them. But the anticholinergics in this context, they basically help to prevent secretions, yeah, or to reduce, the secretions. Remember, during operation, the patient can have secretions in their, in their respiratory tract, secretions in their mouth, and whatsoever, yeah. So those anticholinergics basically help to prevent, they help to prevent secretions, yeah. The too much secretions that can end up, a patient can end up, aspirating, yeah. So medications like atropine sulfate, scopolamine, all these help with, and also prevention of bradycardia, the reflex bradycardia that we talked about. Yeah? All these are very, very important as far as preventing of secretion is concerned. Yeah. So we also have the H2 receptor blockers, antihistamine, or the H2 receptor blockers, or what we refer to as the antihistamine or H2 antagonists. These basically prevent aspiration pneumonitis. Yeah, those medications like ranitidine, cimetidine, famotidine, these basically help with prevention of pneumonitis, but also stress ulcers. Yeah, they also prevent stress ulcers. So those are also examples of medications, preoperative medications that are given to these patients. We also have antiemetics. These ones basically help to increase gastric empty and also decrease nausea and vomiting. A very good example that we usually give is metoclopramide. Yeah, metoclopramide is a very good example that we usually give as far as vomiting, prevention of vomiting is concerned. So those are examples of preoperative medications. Of course, depending on the surgeon's discretion, some people go ahead and give antibiotics. Yeah, some people go ahead and give antibiotics. So antibiotics, depending on the surgeon's preference, some and also hospital policy, some hospitals or some surgeons go ahead and give antibiotics as preoperative medication, right? All right. So basically, that marks the end of the preoperative nursing, or what happens in the preoperative phase. Yeah. That marks the end of what happens in the pre-operative phase, right? And so we want now to move on to phase 2, what we refer to as the intraoperative. Intraoperative. All right. So now in the intraoperative, yeah, of course here we also know what is going to happen. We shall see what happens, yeah, what happens in the intraoperative phase of, or in the intraoperative phase of surgery, yeah. Now, giving, of course, giving nursing care to a client undergoing surgery. And remember, we said when does this start and end? We said it starts from the time the patient is admitted into the operating room up to when the time is transferred to the post-anesthesia care unit, or what we refer to as the PACU. Yeah. So it starts from the time the patient is admitted into ER during the operation until it ends, and then the patient is transferred to PACU. All right. So what are the different activities the nurse does? One is providing, patient safety. That is very important. Maintenance of aseptic environment, ensuring, proper functioning of equipment. We are going to see the different types of nurses in this phase that basically do some of these things. Providing surgeon specific instruments and supplies, completing documentation, positioning, the client or the patient, and then acting as either scrub or, circulating nurse. Now, all those are activities that basically nurses do when it comes to intraoperative nursing. Now, who are the members of the surgical team? As you can see, we have the patient, we have the anesthesiologist or the anesthetist, we have the surgeon, we have the nurses. In here, we have the scrub and the circulating nurse, and then we also have the surgical technologist, as you can see in that diagram there. Yeah. So the patient, of course, is the most important member, and so the patient should be relaxed and prepared, and should not be stressed. Yeah, when they are going to do the operation. Then we have the operating surgeon. The preoperative basically does the preoperative diagnosis as of surgery, and also provides the care of this patient while while they are in their hands. Yeah, performance of the operation, post-operative management and care, and then assumes all responsibility of all medical acts, of judgment and management of this patient, right? So in that diagram, you can actually see the surgeon being helped or being assisted by the assistant surgeon. Yeah? So the assistant surgeon basically scrub and perform the surgery, and then the registered nurse, the first assistant, this one practices under the direct supervision of the surgeon. Yeah, handling tissues, suturing, maintaining hemostasis, and all those things. Yeah. And then we have the anesthesiologist or the anesthetic nurse. This basically administer anesthetic agents and also monitor the patient's physiological status, the physiological status of the patient throughout the surgery. And of course, in here they are monitoring vitals and all those things. And you can see basically that is the anesthetist or the anesthesiologist or the anesthetic nurse. We also have now the scrub nurse. This one basically provides the sterile instruments and supplies, to the surgeon during the procedure, and also performs, surgical hand scrub. Then we also have the circulating nurses. This one basically, just like the word circulating, moves about, throughout the OR to make sure that everything is running on very well. So coordinate care of the patient, in the OR. Also, care provided here includes assisting the patient, positioning in preparation, managing surgical specimens, and documenting intraoperative events. So the circulating nurse basically does not do only one job, but they move, they are on the move to make sure that the surgery is actually going on very well. What does the scrub nurse do? Prepare sterile supplies, counts the sponges, maintenance of sterility, and then gown and glove, the assistant. The circulating nurse sets up a room, maintains supplies, checks safety or function of equipment, positions the client, and then the client claims, the surgical field before draping. Also coordinates all activities, IV fluids, helps the anesthesiologist, and also in documentation. All right, so it is also very important. Remember, we said it is very important to maintain an aseptic environment. Yeah? It is very important to maintain an aseptic environment. Yeah. So it is the role of everyone. Yeah. It is the role of everyone. Yeah. The role of the surgical team to make sure that an aseptic environment is maintained, but most so, the nurses. Yeah. So the surgical environment, of course, stack appearance and full temperature, located central to all, supporting services. We have, as far as the prevention of infection is concerned, we have what we call an unrestricted zone, yeah, where, street clothes are allowed, yeah. Then I think you have all been to theaters, yeah, and all these zones are basically there, yeah. The unrestricted zone, then the semi-restricted zone where attire, consists of scrub clothes and caps. And then we have the restricted zone within the theaters themselves into the operating room, where scrub clothes, shoe covers, caps, and masks are worn to basically prevent infection. Yeah. So it is the role of nurses to ensure that infection is prevented, because if infection is not prevented, then our patients might end up with post-operative sepsis, which we do not want from our patients. Yeah, so that's an example of that's a picture of an operating room. Yeah, a classical picture of an operating room, which we have in most of our hospitals and healthcare facilities. Yeah, so while remember we are in the intraoperative, yeah, we've looked at the people who are supposed to the key people, the stakeholders within this space, and also we have looked at their roles, what they basically do. Yeah. Now it is also very important to look at anesthesia. Yeah, because within here, a patient has to undergo anesthesia. Yeah. So what are the types of anesthesia? And first of all, anesthesia is a state of narcosis, analgesia, relaxation, and reflex flow. Yeah. So a patient has to be anesthetized, yeah, for them to undergo successful surgery. Yeah. And so it involves the use of medications that block pain sensations, yeah, during surgery and other medical procedures. Anesthesia also reduces many of the body's normal functions, stress reactions to surgery, and so the reflexes are actually lost, yeah, as a result of, and especially if it is general anesthesia. Now, anesthesia can be general, it can be local, or even regional, yeah, general, local, or regional. So we are not going to go into the nitty-gritty of these, yeah, but it is very important to talk about them since we are dealing with intraoperative care, or the intraoperative phase of the perioperative nursing. Yeah? So basically, general anesthesia affects the entire body and renders the person unconscious. Yeah. So in other words, it affects the entire body and renders the person unconscious. Yeah. So the patient would then be completely unaware of the surroundings or even feel the pain during the surgery or the procedure. Also, this general anesthesia also causes amnesia or forgetfulness and relaxation of the muscles throughout the body. So suppresses many of the body's autonomic functions such as control breathing. That is why it is very important, that the patient is being breathed for. Then heartbeat, circulation. So it suppresses most of those. Yeah, it suppresses most of those. But the patient can stop breathing, or the heartbeat stays. But anesthesia really suppresses the sympathetic nervous system. Yeah? So things like heartbeat, circulation of blood. That is why there is need, for strict and aggressive monitoring of these patients while they are under general anesthesia. Yeah? So also movements of the digestive system and reflexes, all these are basically suppressed by the general anesthesia. So monitoring of the heart, breathing, blood pressure, and other vital functions is very important. And usually in general anesthesia, of course, there is placement of an endotracheal tube or a laryngeal mask. Yeah, is usually used to give inhalant, inhalant anesthetic and oxygen, and also control the breathing of these patients. Yeah? As they're undergoing surgery. Yeah, and it is very important to know that an ET tube is basically, it helps to prevent, aspiration. I hope you have all seen an endotracheal tube. Yeah, these are basically used in theater, especially during, anesthesia, or even in ICUs when patients are going to be, intubated for placement of, ventilators. So general anesthesia is commonly begun, is induced using an IV anesthetic or inhalation agents may also be used. Yeah, and once the patient is unconscious, then anesthesia may be maintained with an inhalant anesthetic alone, or with a combination of inhalant and intravenous. Yeah. And so the patient basically, stays in that state of unconsciousness until the procedure is done. And so when the procedure is done, then this anesthesia is withdrawn. Yeah. But it is very important that as the procedure is being done and an anesthesia being administered, then the vital signs or the physiological needs of the patient are being, looked into. Now, what are the stages of general anesthesia? We have what we call stage 1, or the beginning of anesthesia. And here, basically, the patient feels warmth, dizziness, and a feeling of detachment from reality. Yeah, ringing, growling, buzzing in the ears. Now, this is especially common with ketamine. Yeah, a general anesthetic ketamine. Yeah. We will cover these in your pharmacology. Yeah. So still conscious, but may sense inability to move, the extremities. Yeah. And then noises are exaggerated. Yeah. Even low voices or minor sounds seem to be louder and and unreal. Yeah. So unnecessary noises for this matter then should be avoided. Yeah. Then we have stage 2. Excitement or struggling, shouting, or even singing, laughing, or crying. Yeah, avoided. These ones can be avoided if it is given, if the anesthesia is given, slowly and smoothly, or even, quickly. And so this stage involves that, and here pupils dilate. Yeah. but may also contract if exposed to light. And then the pulse rate is rapid, the respiratory rate is usually irregular, and usually it might need the patient to be restrained, yeah, if need be, yeah, because that is a stage of excitement. And then 3, we have what we call surgical anesthesia. Here, surgical anesthesia is reached when it is reached. It is reached by continuous administration of either through the gas or the inhalation vapor, or through the IV intravenous administration of this anesthesia. So the patient is unconscious and lies quietly. Pupils are small, but of course may contract when exposed to light. And then the respiratory rate is usually regular, and the skin is usually pink and flash. Now this is the third stage where now at this point or at this moment, surgery should resume. Rather surgery should go on. Yeah? And then we have what we call the stage 4, which is the medullary depression. Yeah? This is usually reached when there is too much anesthesia being administered. Yeah? And the respirations are usually shallow, the pulse is weak, the pupils are widely dilated, and they may no longer constrict when exposed to light. Then cyanosis may develop with or without prompt intervention. Yeah, and this can usually lead to death. So at this point, it is very important for the surgeon to stop, and then the anesthesiologist takes over to rejuvenate this patient. Yeah, and if this patient has been rejuvenated, then the surgery can continue. So medullary depression is not good. Yeah, medullary depression. You know very well, if you're probably not aware, is that the respiratory center, yeah, the respiratory center, and also the cardiovascular center is basically located in the medulla oblongata. Yeah? But mainly here we are looking at the respiratory center. Yeah? So if there is too much anesthesia given, then that means that there is too much suppression of the sympathetic nervous system, and therefore leading to medullary depression. At this stage, there is need for the surgeon to stop, yeah, so that the anesthesiologist can work on rejuvenating this patient, or even reduce the anesthesia so that the patient can pick up, yeah, and then probably the surgeon can now start, yeah. So the anesthesia is discontinued immediately, and then circulatory support is initiated. Because remember here, the pulse is weak, so you need to give fluid, to help the pulse pick up. Yeah? So something like that. Yeah. Now, the other type of anesthesia is basically regional, and in regional basically involves injection of a local anesthetic numbing agent along or around the major nerves for the spinal cord to block. Yeah. You have seen these. You have seen something. You have seen epidural and spinal anesthesia. You have seen this, especially some of you who are mothers who have given birth and cesarean section. You have experienced some of this anesthesia, yeah? Epidural or spinal anesthesia. But you also have a local conduction block, yeah, as the different subtypes and regional anesthesia. So within epidural is commonly used conduction block. So there is injection of a local anesthetic into the epidural space, which basically surrounds the dural matter of the spinal cord. Yeah? So and therefore it ends up blocking the sensory and the motor and then on the autonomic functions of of that area. And doses are much higher than spinal, because the epidural anesthesia does not make direct contact with with the spinal cord or the nerve roots. Yeah. So in epidural, doses are usually higher. Now, the advantages is that usually there is no headache. Yeah. And the disadvantage is that greater challenge, of by introducing the anesthesia into the epidural space. Yeah, and so basically, if there is incidental puncture of the dura, basically what happens is that they can be, it can transcend up, yeah, up the spinal cord and basically cause, severe hypertension and depression and eventually arrest. So that might be what might go wrong. Yeah. So with spinal anesthesia, I think most of you have seen this. Usually, the anesthesia introduced between L3 lumbar, yeah, the lumbar vertebrae, yeah, L3, or between L3 and 5, or sometimes L3, L4. Yeah. And then it produces anesthesia in the lower extremities. Yeah. And of course, the patient should be placed in, in a neatest position for us to introduce this anesthesia. And of course, as soon as injection has been made, then we need to position the patient on their back. Yeah? And epidural nerve blocks here, usually we have a local anesthetic injected near a specific nerve, yeah, to block that area, yeah. And of course, like for example, in the brachioplexus of the arm, the paravertebral anesthesia of the chest and abdominal wall, and even the transsacroiliac block, yeah, to block the perineum and the lower abdomen. So this is what we refer to as peripheral nerve block, yeah. So local anesthesia basically involves injection of a local anesthetic directly into the surgical area. We have seen this, like for example, the commonest one that is used is lidocaine. Like for example, if you want to start maybe a chest tube, they usually do local anesthesia. And usually it is combined with epinephrine because we know epinephrine is a vasoconstrictor. It's a potent vasoconstrictor. So when it is used in conjunction with the epinephrine, it will basically help with, with reducing, blood loss when a procedure is being performed in that area. So that is basically local anesthesia. The advantages is simple, economical, and non-explosive, and also post-op recovery is basically brief. And usually, the undesirable effects of general anesthesia are avoided. All right, so what are some of the intraoperative complications? We have things like nausea and vomiting. We have things like anaphylaxis, especially to these anesthetic agents. Hypoxia and respiratory complications, especially if you go into the medullary stage of anesthesia, of induction. Then hypothermia, malignant hypothermia. Now this is very, very important, though not common, but it is usually can be a complication whereby a patient following administration of anesthesia, they have a high temperature and their muscles are very, very stiff. Yeah, so that is what we refer to as malignant hypothermia. But we can also have DIC in intraoperative phase of surgery. So basically, those are some of the complications. Yeah. Then the adverse effects of surgery and anesthesia, allergic reaction, cardiac arrhythmias, changes in the central nervous system, and oversedation, trauma to the laryngeal oral nerve, especially when you insert in the trachea tube. Yeah. Hypothermia and also thrombosis. Yeah. So what are some of the gerontological considerations, the considerations for the elderly? Yeah. So these people are at increased risk of these, at increased risk of complications because of their age. Yeah. So basically, they are at risk. They are at increased risk of these complications because of those following conditions. Like they can either have a coexisting condition, their age, decreased hemostatic mechanisms, or even changes in responses to drugs, yeah, or even yeah, there are changes in responses to particular drugs. But remember, their livers and kidneys are also aged, so the way they metabolize and even excrete these medications might be a problem. So there is need to consider these elderly as you're giving anesthesia. Yeah. Now, what are the nursing goals for a patient in the intraoperative phase? One is reducing anxiety, positioning to avoid injuries, maintaining patient safety, maintaining the patient's dignity. Only operate where, only expose that area which is going to be operated upon, and then avoid complications. Yeah? So those are some of the positions that are ensured. Now it is very important to support those arms, by the way. Very, very important to have those arms. Yeah. Because if a patient is just operated upon and if the arm is hanging here, they can end up with that arm being damaged. Yeah. So it is very important to support those arms during surgery. So those are some of the positions that are assumed for certain surgeries. Yeah. So protecting the patient from injury, it is very important, like to do patient identification, informed consent, record results from diagnostic tests, take a history of allergies, and then monitoring and modifying any physical, environment. All right, safety measures, and then verification of accessibility, verification and accessibility of lab. Now, basically, that marks the end of our intraoperative phase. Yeah. And now let's look at the postoperative. Yeah. The postoperative phase. Yeah. Let's look at the postoperative phase. Now, in the postoperative phase, remember we said, when does this one begin? It begins with the admission, of the client into PACU, and it ends, when the client is even discharged home and is under, continuity, is basically discharged home, yeah. And so that is basically the post-operative thing, yeah. And so, what is PACU? Remember, we said it begins with admission into PACU. Yeah? So, what is PACU? Post anesthesia care unit, yeah. And so what do nurses do in PACU? Provide care for a patient until he or she has recovered from the effects of anesthesia. Patient has resumption of motor and sensory function. It is also very important to monitor vitals and to see that the vitals are stable. Also, it is also very important to monitor any bleeding. Yeah, so you need to make sure that the patient is not bleeding. Yeah, and it is also very important to observe for any complications of surgery. Yeah, so all these happen when a patient is transferred to the post anesthesia care units, or what we refer to as the PACU. Post anesthesia care unit. So, of course, frequent field assessment of the patient is very, very vital when we are into practice. Yeah? Now, what are the responsibilities of the nurse in PACU? One is review pertinent information and baseline assessment upon admission, of the patient on the unit. Basically, assessments include airway and respiration, cardiovascular assessment, surgical site inspection, you inspect the surgical site, for any bleeding, function of the central nervous system, performing the Glasgow Coma scale score. Of course, you will cover this more. Then assess, assess all the IV sites, yeah, the intravenous sites and all the tubes that have been attached on the patient, yeah. We assess vital signs, and pertinent status every after 15 hours or even or more frequently. Yeah. Maybe I should also mention here there is what we call the rule of the rule of 4. Yeah, especially like in PACU. Yeah, you do 4 times. Yeah, 4 times. You're supposed to do 4 times. Yeah, every what? Every hour. Yeah, 4 times every hour. Yeah. So that basically means 4 times every hour. That is, every 15 minutes. Yeah. But as the patient goes on improving, then you can do 4 times. You can do 4 times every 4 hours. Yeah. If the patient goes on improving, then you can do 4 times every 4 hours, and that is when you do 4 times every 2 hours, then that means every after every after 30 minutes. Yeah, and then you can upon improvement, if the patient goes on improving, then you can do 4 times every 4 hours. So that means those are four. Rather, that means you're doing it every hour. Yeah. So that is what we call the rule of 4. Yeah, the rule of 4. When during monitoring of the surgical patient. Yeah. So, however, if the patient is still critical, please do not move down. Yeah. If the patient is still critical, maintain the 15 every after 15 minutes. Yeah. Or even more frequently if needed. Yeah. Then provide report and transfer the patient to another unit. Yeah. Or discharge the patient at home. Yeah. If it was a one-day surgery. Yeah. If it was a one-day surgery, after PACU, then the patient can be fit to be discharged home if the patient has stabilized. Yeah. So basically, those are the responsibilities of the PACU nurse or of the patient, of the nurse who is in the post-anesthesia care unit. Now, outpatient surgery stroke direct discharge. This is the one-day surgery that we are talking about. So discharge planning and discharge assessment. Yeah. Provide a written and verbal instructions. So if the patient is going to be discharged, provide a written and verbal instructions on what the patient will do regarding follow-up of care, complications with care, activities, medications that the patient should be on, and even that. Now, these are basically done by the surgeon. Yeah? These are done by the surgeon. And the role of the nurse in this context or in this role is to basically reinforce. Yeah? Then give prescriptions and personnel numbers, discuss action to test with complications occur. Yeah, so this is for outpatient surgery, or what we call one-day surgery or direct discharge. Yeah. So give instructions to the patient and responsible adults who will accompany the patient. You also patients who are not who cannot be able to drive themselves home or be discharged to home alone. Sedation and anesthesia may cloud memory and judgment and even affect ability. So in such patients, then they need to be, in such patients, then the patients need to be driven home. Yeah, they cannot drive themselves home because of the effects of anesthesia and sedation. So also very important, especially in the PACU, yeah, especially in PACU, but also in intraoperatively, it is very important to maintain a patent airway. Yeah, so it is the primary consideration necessary to maintain ventilation and oxygenation. Yeah, so provide supplemental oxygen as indicated. Assess breathing by placing a hand near the face. Yeah. to feel movement of air. Now this is done in fact because at this moment the patient is now, you know, breathing on their own. Usually the endotracheal tube has been removed, yeah? And so you need to make sure that the airway is patent, yeah? And so how do you do that? Assess breathing, keep the head of the bed elevated unless contraindicated. The patient may require suctioning. So suctioning should be at the bedside, especially for every PACU patient, yeah? It should be at the bedside. And then if vomiting occurs, you know, you turn the patient aside to prevent aspiration, yeah? So there's what we call the head and jaw positioning to open the airway, yeah? Usually you position, as you can see there, you position the patient like that, and then you tilt the head a little bit, yeah? To kind of like position the airway, yeah? And then there is also what we call the jaw thrust, yeah, whereby you hold the patient in such a position to be able to, you know, open the airway. So basically, you can also use an oral airway. You can also use you can also use an oral airway if probably the patient is unable to maintain, you know, is unable to maintain, you know, an open or patent airway. And so basically, that marks the end of perioperative nursing, yeah. And in this, we have of course looked at the phases, and we have looked at the phases of nursing of perioperative nursing. We said we have the preoperative, we have the intraoperative, and then we have the postoperative. And we've seen who the stakeholders, yeah, who the stakeholders in this are, yeah, and the different roles that nurses perform as far as you know, this perioperative nursing is concerned. In intraoperative nursing, we looked at anesthesia, the different you know, types of anesthesia that are basically given to this patient. And basically, that marks the end of our perioperative nursing. Next time, next time we shall look at something else. Yeah. Next time we shall start with the respiratory conditions. Yeah. So basically, that marks the end of our presentation. Make sure you watch this presentation up to the end. Thank you so much.